Good afternoon, everybody. Thank you for joining us today. My name is Victoria Smith, and I am a marketing associate here at Exscribe. I'm excited to welcome you to our presentation, Collecting More for Less at Your Orthopedic Practice. All attendees are in listen-only mode right now. If you take a look at your control panel, there should be a small hand icon displaying. If you could just click that icon and raise your hand, I'll know that everybody can hear me okay. Perfect. I see some hands raising. Thank you very much. So if you do have any questions during the presentation, you're just going to want to type those into the questions tab. That's also found in your control panel. We are going to try to get through as many as we can at the end of the presentation. And just so everyone's aware, the webinar is being recorded and you will be notified by email when that's ready for you in a couple of days. So now it's my pleasure to introduce Raj Vadaraju, CEO and founder of Health iPASS, who is our expert speaker today. Health iPASS gets practices paid from patients in a way that their patients love. They have pioneered several innovative features such as touchless check-in, virtual waiting rooms, price transparency, and text to pay to streamline patient check-ins and payments. Raj is a published author and experienced speaker. And today he'll be walking us through a comprehensive look at optimizing patient collections specifically for an orthopedic practice. So without further ado, I will turn it over to Raj.
Thank you, Victoria. Thank you for that great introduction. It's my pleasure to meet with you all this afternoon and share our thoughts, and these are thoughts that come from working with thousands of providers across the country in this rather tumultuous time. And it's a great topic, right, and very timely about helping you collect more for less at your practice. And I'm eager to kind of share our experiences. I want to first start with a big thank you to all of you, our clients and prospective clients, and all of you healthcare professionals for keeping our country's healthcare alive. It's a time that has tested the emotional intelligence of lots of people, and we are very, very grateful that you guys do what you do and serve the people that are really in need day in, day out. And what I'm sharing with you guys today, like I said, is really the collective wisdom of a number of leading practitioners across the country that we have had the fortune and pleasure of working with. As the agenda kind of first laid out, I'll cover three broad areas. The first is, let's step back and take a holistic look at what are the costs associated with patient collections. Second, some metrics and ways to look at the efficiency within your practice surrounding patient collections. And that will segue nicely into what some of the leading practitioners across the country are doing in terms of bringing efficiency, particularly against the backdrop of this post-COVID world that we live in. And finally, we'll kind of conclude with getting a good view of what the economic impact looks like in terms of patient collections for typical orthopedic practices. And we work with a number of them across the country, from those that are like in the top 5 in the country, all the way to many practices that are anywhere from 5 to 50 physicians sort of in size. Then we'll kind of open it up for any questions and any comments from the audience. So let's kind of jump in. I think if we look at the broad picture, it's an interesting time, right? COVID has certainly thrown a curveball at a lot of us. The world has almost turned upside down in some cases, and I think we all are very, very fortunate and lucky that we are in healthcare, an industry that has been relatively a little bit more insulated than most other industries. And in fact, I would say I'm glad and I'm fortunate that I'm in healthcare. But this is a phenomena that has affected every practice across the country, right? We're seeing less patients. Some states are maybe up to 70, 80% of their pre-COVID volume. Some may have done slightly better. In the course of the last several months, there have been forced reductions in staff, reductions in some cases because people got scared of being on the front line in an industry that is a little bit more exposed. And it's also a time where, given the cash flow pressures and the financial pressures that we've had to make some adjustments to how we are staffing our practices. And certainly during this time, from a collection standpoint and cash flow standpoint, we've seen some payers make adjustments in their own schedules in terms of, particularly in the month of April, lots of our clients have seen delays in terms of getting the payer side of the revenue streams. And certainly, the challenges that we've all had in terms of collecting from patients. Certainly the last few months, people are afraid to even open their mail, let alone, go out and find a checkbook or find a stamp to send in their bills. And I think all of this has meant that we have had a chance to kind of look at the workflow within our practices and say, what's a way for us to not just survive and adapt to this new world of COVID, but really look for efficiencies in terms of how we can get better in terms of serving our clients. And, the patient base, when you look at it from the other side, the last 5 years have seen a very drastic shift in where our monies are coming from. Receipts for us, a greater portion of that is coming from patients. Patients are all on high deductible health plans, except for maybe people that are on Medicare and have supplemental plans. And it certainly had been interesting in terms of how practices have evolved in dealing with the patient as a payer. And most of our clients across the country, what we tend to see is, the patient as a payer class is usually either at the top of the list or maybe second to a Blue Cross or whoever is your most dominant payer. And it's a pretty significant part of, how we will survive and how we will thrive as a practice. And I think the expectations of the consumer are drastically different today than what it has been maybe 10 years ago, when I didn't have to worry about paying for healthcare as long as I had an employer-sponsored plan. Every industry, whether it's the Uberization that we have seen, whether it is, literally any industry, they have seen a greater push for convenience and transparency. And the challenge that we all know in healthcare is it's the only industry where we as a merchant have no guarantee that we will get paid because, a lot of it is coming from the patient out of pocket. And looking at from the consumer standpoint, unless you walking into a Starbucks or your favorite restaurant or what have you, you as a consumer really don't have, the type of convenience that you would expect in other walks of life, nor the understanding of what your out-of-pocket cost is. And they go very much hand in hand. So that's sort of the broad sort of a backdrop that we are obviously all dealing with. If you ask yourself the question, why should I care and how much is this worth? What we have seen across the country is it's a lot of money. It's over $100,000 per provider per year that is probably at play, and it's a big enough kind of a bucket here that this is an important topic for us to kind of look at. What does this mean when we think about the cost of patient collections? Now, when we think about cost of patient collections, our clients tend to think very broadly about all the steps involved from the time a patient needs to get on the schedule and comes into our door, from a pre-arrival standpoint, to the activities that we have to do when the patient does walk in the door, both during check-in as well as check-out. And then the third big piece is after the patient walks out, and we know very well that there will probably be a patient responsibility after this person walks out. What are the activities associated with collecting the dollars that are the patient responsibility after the patient leaves? And that's the post-visit part of the patient collections. And I'll try to go through kind of each of the items and talk about it in a little bit more detail. And of course, welcome questions and comments from all of you guys that are practicing the administration and financial, health of your practices. So talking about pre-arrival, what are the costs involved on your side when you think about scheduling a patient, right? Is this a new patient? Is it someone that is coming back for a follow-up visit? If it's a new patient, how are we verifying their benefits? What is our process in terms of catching any kind of exceptions, beforehand? What does our pre-registration process look like? Is it, something as simple as a PDF that we put on our website versus any electronic methods that would make it easy and convenient for the patient to be able to complete that? What's our success in terms of getting people that have taken an appointment to actually show up, right? And what does the costs involved in terms of sending out reminders, whether it is calls, text messages, or emails, and what's the right cadence that will assure a greater level of participation, right? And also related to that, of course, is how are we handling and how are we set up to handle, any kind of reschedule requests from the patients or cancellations. Cancellations are great opportunities to really make sure that we get a person inside of our call center to be on the phone with the patient, to be able to look for ways to accommodate them, maybe a little bit later on. And all part of the front end work is also the financial clearance. So whether it's an expensive diagnostic like an MRI, for example, or any kind of surgical intervention, what are the processes that we have set up and what are the associated costs, both in terms of staff time, in terms of the external tools that we may be using, in terms of obtaining this financial clearance. And these are, 6 broad buckets in terms of where costs, are present in terms of thinking about the total cost of patient collections. The second big area, of course, is what happens when the person comes in the door, right? And certainly with COVID and safe social distancing measures, this has kind of been tricky, right? People don't want to touch a clipboard. People don't want to touch a pen from a cup of pens that we have had at the front desk. There are questions about, even if you did get somebody to take a clipboard and sit down, they're really concerned about how much time they're spending in a clinical setting as a consumer. And with that comes the risk of perhaps maybe cutting some corners in terms of the things that we really need to do from a registration standpoint, making sure that we have a proper insurance, making sure that we have the front and back copies of their insurance cards, making sure that we have, verified their insurance through a clearinghouse or what have you. And all of the administrative and clinical forms that we need to collect, right? Collecting, your financial policy, your HIPAA policy, your medication history consent, your assignment of benefits, any of those type of consents that you are required to collect from the patient, as well as all of your new patient packet when you talk about the general family history, past medical history, surgical history, allergies and medications, things like that, as well as in lots of cases, I would imagine across the different subspecialties that you guys have, you probably have, physicians like my brother's an orthopedic doc, and we all know, bless their heart, but they have their own set practices in terms of, how they want to treat patients and what kind of data they expect and want us to collect as part of registration. So your neck doctor might have a specialized form, or your hand surgeon might have his own specialized form. And on top of all of that, right, what has always been tricky gets even more trickier in the backdrop of this COVID world that we are in, is how well are we set up to be able to present and collect in a very discreet and very respectful sort of manner to the patient, instead of asking them about the balance that they have with 6 other people in the waiting room kind of overhearing it or what have you. How well are we able to present and collect the balances and copays, and not just collect it, but you also have to run the transaction on a swiper, perhaps create a receipt for the patient, certainly post all of that money back into your practice management and billing system. And this activity is not just on the point of service from a check-in standpoint, but all these things also come up during checkout. And a big part of that, and something that we see a very broad and universal sort of almost craving for and demand for, is from the consumers and the patients saying, what would this cost me? And don't shock me with a piece of mail later. Tell me upfront what my out-of-pocket cost is going to look like. And that's a big part of making sure that you are thinking about price transparency on the front end. So with all this work, right, we find out that lots of times we submit the claim to the insurance company only to find out that there is a pretty substantial portion of revenue and receipts that are tied to the post-claim adjudication responsibility of the patient. And that's where a second kind of a revenue cycle process kind of kicks in for us, sending out paper statements, making follow-up phone calls, hiring, at 15, 20, 25% contingency, collection agencies that can try to collect in a little bit of a brute force sort of way of the monies that, perhaps, could have been collected, differently from the patient, and certainly comes with all the post-visit collections, the activities surrounding sending receipts to the patients, to, posting into the practice management systems, and any kind of refund management, void management type of processes that you have to kind of look at. And as you see, it's 20 different boxes of various activities, and this is probably, hopefully we've covered a big part of the type of activities that occur, but also certainly there is end of day cash reconciliation, for example. There is, if you collected lots of cash, how you actually deposit them into your bank account. And there's a number of ancillary processes that are tied to the revenue cycle that both add cost and time. And in a lot of cases, the bigger prize here is that there is still a lot of money sitting in the AR, and particularly in the AR from the in the 91 to 120 day bucket, which usually tends to be a really good indicator of what is sitting out there. So one of the questions that that always comes up is, what are a handful of easy measures to look at the effectiveness of your revenue cycle? And for those of you that might be interested, we actually do a very detailed pro bono sort of analysis of your revenue cycle, on the patient side. And a big part of that is to look for metrics that you may be used to in terms of looking at it holistically across the organization, across both payer as well as patient side revenue. But the ones that are important to sort of tease out, almost like your vitals, is to look at your patient net collection rate, your patient side revenues, days in AR, what portion of your patients you're billing through paper statements, and the number of paper statements that you generate is probably a good proxy, because anytime you're doing semi-automated or unautomated, kind of the old way, if you will, there is certainly all those costs that we talked about in the previous slide that come into play. And an important part is really the front end part of what percentage of the patients that are coming into your clinics, you're already taken care of what you need to do from a check-in standpoint, whether it is registration, whether it's collecting their insurance, whether it's validating their insurance, whether it's collecting things like selfies, driver's licenses, so on and so forth, the kinds of things that you associate with registration. But very importantly also is your consents, your disclosures, your various types of policies that you may want to collect from the patient, and all of the activities surrounding money in terms of presenting that discreetly, being able to collect that with the convenience of 2 clicks on their phone, as opposed to doing something in-house. And these are 4 of many different metrics that we look at. This, generally surface to the top in terms of the key metrics that we look at. And just for the sake of clarity, I just want to drill in on one, the patient net collection rate, because there's a lot of terms people throw out. And I look at it in a very, very simple fashion in terms of thinking about this net collection rate. At the end of the day, it's what you collected over the total collectible dollars. So if you add as denominator what you collected plus what's sitting out there uncollected, that ratio tells you the entire story. And in a simple way to think about, businesses that do cash-based accounting, as most practices tend to be, the collected number, every one of you guys, it's a pretty easy number that you guys probably can just rattle off at the top of your head. It's the amount of money that is coming from patients, it's the self-pay dollars or whatever terminology that your practice management system may be using to attach to it. What is often not so easy and not very visible to you is what's a good way to think about the uncollected portion of the patient dollars. And what we submit to you is if you look at your patient AR and you look at the 91 to 120 day aging bucket, that usually is a really good reflection, because not only has the claim been adjudicated, but you probably have done 3 rounds of follow-up in your traditional 28-day dunning cycle to try and collect that money. And so far, those attempts have been unsuccessful. And that usually tells you a really good story about the health of the net collection rate within a practice. And oftentimes the macro picture, like what MGMA and other great organizations obviously recommend, somewhat obfuscates the actual number, because it's hidden behind what are both payer dollars as well as patient dollars. And I think MGMA and HFMA have a number of statistics that they have released. The macro picture is this ratio tends to be about 2/3. So most practices nationally are collecting somewhere in the vicinity of 60 to 67%. And of course, there's a whole bunch of cost that is associated, but just looking at it from a collection rate standpoint, that's typically kind of what we see across the country before, Health iPASS starts to work with a particular client. So enough about, I guess, cost of patient collections and cost of and the metrics that we look at in terms of collections. I'm going to switch gears a little bit and talk about scenarios and how we, along with our clients, kind of think differently about this whole patient revenue cycle. So I'm going to take myself as a guinea pig here. Let's say I walk into your clinics and I, during scheduling or during any one of your registration processes, basically tell you that I am on Aetna. I've got a PPO plan. I give you my address, phone number, email, so on and so forth, some of which you could verify, some of which is probably you're just going to take my word for it. At the end of the day, most practices do a pretty good job, even though there may be costs involved and it may be labor intensive and so on and so forth, of getting me to provide a copy of my insurance card. Most practice management systems even give you an opportunity to run the benefits and be able to look at my benefits. And, there's lots of people like me that have a piece of plastic that we are, carrying in our wallets. But behind it, if you actually drill down, these are high deductible health plans. In my case, as of a few days ago, I still have most of my $3,000 deductible intact. And on top of it, I'm on a 90-10 plan, luckily. There's a lot of plans out there where we see 30, 40, 60% even co-insurance in some cases. And there is as much as either $3,500 or almost $4,400 that are at risk for your practice. So I walk into most practices, they look at my card, at best they'll run their benefits. They say there is a $0 copay for Raj. So I pay nothing. And unlike any other industry or any other walk of life, I have no idea what services they have provided, how it's going to be billed to the insurance company. Are there any ancillaries involved? Maybe I got an injection. Maybe there were certain, X-rays and diagnostics in the musculoskeletal world. Maybe there's some DME that is dispensed. And typically, I walk out of the practice without paying anything. And obviously, I'm anxious at that point to know what is the patient out of pocket and what's the surprise in the mail, right? And, the practice very well knows at the time they're going to submit a claim to Aetna 3 weeks later, 6 weeks later, whatever the duration might be. What happens in my case is 100% of whatever the practice is going to get paid is going to come from my pocket. And the big question that it leaves in most cases is, will Raj pay? When will he pay? And how will he pay or prefer to pay? And what kind of follow-up activity would be required to get Raj to pay? And that's the really big question that plagues most practices. And this plays, this type of scenario plays, out, 20% of the time, patients that are walking into your clinic are probably new patients. If I came back a month later and there was a more expensive diagnostic involved or some physical therapy or some EMG or any procedures that are involved, same scenario kind of plays out because I'm still sitting out there with a $4,000+ out of pocket. That is the financial risk for your practice. And it gets worse, of course, if I need surgery or any kind of surgical intervention. Again, in my case, and cases with lots of people that are walking into your clinics, it's the high deductible health plans that obviously are creating this sort of a challenge, right? So when we look at the collection opportunities and best practices around collections, what we have pioneered is really flipping this attitude of bill later to, hey, this is no different than a Starbucks. This is no different than any other consumer experience that anybody has. Let's literally flip, what has been invented maybe 50 years ago as a revenue cycle process where, the patient paid pretty much nothing, right? The insurance companies' reimbursements were pretty, remarkable in those days. Everything was either paid by the government or the insurance company. And, we're still living in this world where even though about 30% of the receipts are coming from patient out of pocket, 20% at the very least, it's still set up and geared for a bill later sort of an attitude. And what we look at is what are all the opportunities and how can we invert this model pretty much? How can we be upfront with the customer, with the patient, and at the same time, just like any other private business, really be able to demand that we get paid for what is required. And, lots of practices do a really, really good job of collecting copays. And unfortunately, in my case, as I showed you, I don't have a copay. So the risk is really 100% of the receipts, or a really big portion of the receipts are coming from the patient. And they're coming in a way that the age-old approach of sending a statement and hoping and praying that, we'll get paid is just not translating. And particularly at a time when all the physicians or their spouses or whoever's yelling at us about, the decrease in cash flow over the last 4 months, it's a time for us to sort of reinvent ourselves and say, what can we do differently about what's the best way to structure our workflows related to all of the things that we talked about, pre-arrival, at the point of care, as well as post-visit. So we think about the opportunities that you have in terms of presenting and collecting patient balances, right? Give the patient an opportunity to, through their text message, through an appointment reminder email, remind them through the voice calls that they receive on the front end, but not just give them, hey, show up at this time at this place, but something that allows them to be able to do all the things that you typically required them to do in person. And, putting aside, the health iPASS hat for a second, what I'll take you through is how practices are thinking about efficiencies across all 5 steps that you see here in terms of the patient journey, and what sort of best practices you're kind of seeing out there, right? I'll start with the pre-arrival engagement, right? Lots of you guys probably have appointment reminder systems. Companies like us have a very, very robust appointment reminder system, but it's not just a simple reminder system that you typically see. This is giving them an opportunity to call a lift or, get, turn-by-turn directions to where they need to go. It's giving them an opportunity to completely complete their check-in process from the comfort of their phone, right? Being able to get a text message, being able to complete registration that includes, their selfie, their contact info, ethnicity, gender, race, emergency contact, pharmacy, all of the detail that you need from a MIPS and MACRA standpoint. Very, very importantly, collecting insurance info from the patient, not just what insurance they're on, but real time validating that the insurance is valid, making sure that we provide the transparency to the patient upfront in terms of what their benefits are. So in my case, it would say, hey, Raj, you probably knew that you don't have a copay, but did you also know that in your case, you still have $2,700 remaining on your deductible, and do it in a very simple fashion that is understandable and easily digestible by the patient. And as you can see, the patient experience, we really, really take to heart in terms of making sure the image that we are projecting on your behalf for your practice to your patients is one that really inspires confidence. It gives them clarity. It, gives them an opportunity in a few minutes or a few tenths of seconds basically get through what they would have normally come in 30 minutes in advance into your clinic for. And that includes not just registration, but very discreetly presenting to the patient what balance from prior visits they owe your practice. In one click, being able to go through and look at all of those details, not just pay for past balances, but also what could be due from the patient for this visit. And that could be a copay, something as simple as a copay. If it's, coming in for a PT visit, for example, it's the PT copay. If they're coming in and seeing an advanced practitioner, for example, it could be the quote unquote, the primary care copay versus the specialist copay if you're in a multi-specialty group. And something that we have really pioneered is, particularly in cases like these high deductible health plan patients, not just look at copay, but be able to glean from your historical claim data what really would be the patient responsibility in terms of the typical services that you provide, like what's the lowest common denominator in terms of the services that you provide, and using your rate cards and fee schedules as well as old claim data, essentially determine through artificial intelligence what the patient portion would look like and present it before the patient even walks through the door. And depending on how hard you want to enforce it, you could collect that upfront and collect also a authorization, like a card on file, for example, where the patient is authorizing you, not giving you an open checkbook, but authorizing you for a specific visit, anything that could become the post adjudication patient responsibility. And the patient can do this from the comfort of their phone. There is no apps to download. There is nothing for them to install. They can do it on their, phone, laptop, PC, tablet, whatever the case may be. And that includes everything that you typically associate with the paperwork that's required, and not just a standard one-size-fits-all type of a packet, but very customized to that particular patient for that particular occasion of service. So if it's a PT visit, it's whatever you require for PT visits, right? If it's a new patient coming in for PT or a brand new patient that is coming in to see a physician, what's the right packet of data? And we are extremely, extremely thrilled and happy to work with Exscribe in a exclusive partnership where we are integrating this into the Exscribe patient portal, and you can use parts of this functionality today in terms of creating a better pre-arrival sort of an engagement for your patients. And optionally, of course, there is the Health iPASS revenue cycle kind of product line that is going to help you collect the money portion, run the benefits, and all of the other fancy stuff that I'll talk about. But a big part of this is to really get in the backdrop of COVID, how can we create a contactless and touchless registration process, and not just a data collection process, but the right intelligence embedded to it to maximize your opportunity to collect. In fact, we've gone to a point with a very large, probably one of the largest, neuro and spine groups in the country, where they have pretty much obviated the need for doing any kind of statements, whether it's paper or electronic, because the smart deposits and the cost estimator from Health iPASS has been really on the money in terms of predicting what the patient out of pocket would look like, and leveraging the intelligence of what services were provided across many years of data specific to that type of appointments by that particular subspecialist physician or what have you. And again, very, very customized in terms of what that experience looks like. You guys may have seen, and many of you may even use a kiosk, if you will. The challenge with kiosks, of course, is there is still some lingering concern from patients. Obviously, the device has to be, sleek enough for you to be able to wipe it down and disinfect the device for people to be able to use in 30, 60 seconds or less. It's a way for patients to kind of do the things that perhaps they haven't done through the express check-in process. And a big part of that is also to really leverage this cost estimation engine to be able to present an EOB before the patient walks out, or be able to not just present an EOB, but also collect on that EOB before the patient walks out. The more we can do on the front end before the patient walks in or while the patient is in the clinic, that, as we all know, is the highest chance that we have in terms of getting paid. And if you look at your receipts as a function, your time of service receipts as a function of your total receipts, a lot of practices across the country tend to be in the 4 to 8% range, 4 to 11% maybe range is what we have seen. And that is kind of the old style of I will bill later versus what through necessity and through evolution, what the market leaders are just looking at is how do we flip that on its head and really collect more of that upfront. So a good model would always be able to look at how many people are walking through the door, how many have we checked in through our, whatever is our check-in process, how well have we collected a card on file. And we have clients nationwide, even in some really troubled neighborhoods and so on and so forth, where they get anywhere from 85 to 97% of the patients leaving a payment assurance, if you will. And it's not a blanket authorization to be able to bill for anything. It's a specific authorization just for that particular occasion of service or something else like a surgical intervention, for example. And the more we are able to electronically communicate via text messages, via email messages, the more you will see that there is a greater opt-in. And that certainly helps if there is parts of the bill that are non-deterministic, not easy to determine on the front end. You're able to use this as a way to now shift from paper statements to electronic statements, whether it's sending them a text as soon as the claim is adjudicated or an email, if they have left that card on file, automatically kind of being able to say, here's the patient responsibility after the claim has been adjudicated, and not just dealing with AR after a solution like this may have been implemented, but also looking at pre-health iPASS AR and presenting through, looking at the bill size in your AR and the recency of the bill and turning that into what I would call AR rundown campaigns, if you will. People are not opening their mail. People are not reacting to paper statements. They probably weren't before, but this time they certainly are not. And it's a matter of providing that convenience, whether it's flexible payment plans for some clients, for some patients, or providing the convenience of one click or no click if I have left a card on file. And these are ways that certainly the market leaders are evolving their approaches to getting collected. And of course, every one of these requires a very strong management system that gives you the right type of tools to look at your effectiveness at an individual location basis, drilling down to maybe this person at the front desk does a phenomenal job of collecting card on file, converting prior balances, so on and so forth. And maybe somebody else is not quite doing, as good of a job, But being able to look at metrics like that and operational metrics like that is a big part of obviously being able to measure success. And I think across 3.5 million check-ins that our clients have done through the Health iPASS platform, what we were stunned by is literally if the patient checks in through Health iPASS, the practice got 97 cents on the dollar. And that's a remarkably different number than what typically we see before we implement our solution, right? We go in and see large write-offs, lots of bad debt. There's a high cost of this manual processes end to end. Their days in AR are really high. And what we are putting in is every dollar incremental that is collected that is going to shave off your AR in the 91 to 120 day bucket is going to drop through as operating income. You get paid literally 7 days after the claim is adjudicated. But very, very importantly, in this tough competitive market that we all live in, it's an experience that is going to set you apart from the other practices on the street that may be still stuck in the old ways of doing something. And for those of you, I'll just make a very shameless sort of a plug. If you're interested, you can go to our website, healthipass.com, and there is a simple cash flow calculator where you can select your specialty, the number of physicians. It kind of prompts based on industry data that we have specific to orthopedics, a rough estimate of what your total practice revenue might look like, what your AR might look like, what your patient collections might look like. And you just plug in a couple of numbers there, and it'll give you a really good view of what to expect and what could be the incremental recovery opportunity for you guys from a profit recovery standpoint. And certainly we welcome an opportunity to engage directly if we are not already engaged to really talk more about how we could potentially be of help. So with that said, I'm going to stop talking, catch a breath, take a sip of water, and turn it over to Victoria to field any questions that anybody might have.
Thank you so much, Raj. That was really informative. I'm just going to give a couple minutes here. If anybody has any questions, you can use the questions tab in your control panel on the right and just type those in, and I will see what we get here. I know one fact that struck me was that 60% collections rate ratio across the nation. I just didn't expect that to be as low as you guys have found.
Yeah, it is. It is surprising, right? I mean, when you look at any payer, if it was Blue Cross and they said, I'll pay you 60 cents of what already is a crazy low reimbursement, we wouldn't survive as a practice, right? And yet it is shocking, and maybe not shocking when you actually peel the onion and look at the layers of complexity here, but typically it's really surprising to people when you really look at the hard numbers don't lie, right? And it's a really simple calculation to look at what's in your 91 to 120 day AR versus what you are collecting from patients in a given month. And on a steady state basis, that literally gives you a good idea of what your effective patient net collection rate is. And most billing systems, Victoria and everyone else on the call, we all know when you look at the holistic picture, you can hide in some ways the inefficiencies of the patient revenue cycle because it's clouded by the 70%, 80% where you are getting 95%, 98%, 99% yield or your net collection rate from typical payers.
Okay, we have a question from Paige. She's asking, do you have to be on Exscribe PM for the system to work?
Hey, Paige. The answer is no. We work with a number of practice management systems in addition to our integration with Exscribe, both the EMR as well as the PM. We have integrations with many different practice management systems, from the Athenas of the world to Epics of the world to Centricity, ECW, Allscripts, lots of different practice management systems that are out there, NextGen, so on and so forth. And happy to talk more. But yeah, we can integrate on one side to Exscribe for the clinical portion, and separately for all the revenue cycle portion, integrate with whatever your practice management system is.
Great, thank you. We have one more question here. One thing I haven't looked at in detail is the cost of sending paper statements. Are there any statistics on the adoption rate of e-statements or text to pay?
There are. So I think the national statistic to start with is it takes something like 3.4 statements before, on an average across the nation, for those bills that get paid. Now, when you think about that, and you think about a 30-day dunning cycle, it's no surprise that we have, as medical practice specialists, we have conditioned the healthcare system in the country to never pay on the first bill. I hate to say it that way, but that's the reality of how the consumers have been kind of conditioned over time. And I think it's high time for us to really shift gears and think about a better experience for the patient. For the most part, what we have found is it's not the propensity to pay that is at play here. What we are suffering with is, death by a million paper cuts, right? Lots of your AR, if you look at, and do some analysis on the number of bills that you have by bill size, lots of bills are less than $100. Lots of bills are less than $250, right? And it's not really the propensity to pay that is getting in the way here. It's really also about how convenient it is and how easy it is that we have. So while you typically talk about medical bills having 6% to 8% open rates and payment rates, what you typically find with text and email and electronic statements is as high as 80 to 90% sort of open rates. And particularly when you combine that with auto debits, it's literally no cost, at least within our platform, it's all part of the service. There is really no cost to sending, 2 more text messages if the patient owes you, more than a $250 balance, and making it convenient for them to be able to be informed if you use the card on file to be able to collect. And that's really the secret of how we get to 97%, is to really encourage the price transparency and the convenience upfront, get people opted into a card on file program, flip the model on its head to collect more upfront, so you don't even leave it for chance that there would be a post-adjudicated patient responsibility as best as you can. But if there is something that is, left for payment after the fact, it better be a small portion of the overall patient dollars that are billable. And the big part, like for example, in my case, if I walked into a clinic and I saw, let's say, your hand surgeon or what have you, chances are there will probably be an X-ray. There's probably going to be a level 3 or a level 4 consult. And knowing fully that I'm on a high deductible health plan, why would we not collect at least a deposit, but not just any deposit? It's using the intelligence of what we know are the services that are provided. And we can true up after the claim is adjudicated using that card on file. So in my case, in that example, a big portion of the E&M code and maybe a lowest common denominator diagnostic code is estimated, run through the cost estimator using my benefits, using the client's fee schedule, and collected up front. And also collected is that card on file to true up for just that visit after the claim is adjudicated. And therefore, the bills that we are presenting on the back end are smaller bills as opposed to what you tend to see without this process. So a big difference between paper statements and the expense associated with it and what the collection rates tend to look like versus a fully automated electronic process where effectively you're able to get 97 cents on the dollar.
Yeah. Well, great. Thank you so much for those comprehensive answers. And this was an awesome presentation. I know I learned a lot. I think we answered everybody's questions too. So thank you so much for joining us, Raj. And thank you everybody for attending today. Just a reminder, this recording will be made available to you by email in a couple of days. And I hope you have a great rest of your day today. Thanks so much, everybody.
Thank you so much, Exscribe, and thank you everyone for joining. Look forward to hoping to have a chance to speak with you guys separately. Thanks again.
Thanks. Bye.